Are low-dose anticoagulants safe and effective for people with advanced kidney disease? Is it cost-effective to add H. pylori screening to colorectal cancer screening? Could a large multi-cancer screening trial delay diagnosis for other patients with suspected cancer? This and much more on today's JAMA Editor's Summary. Hello and welcome to our listeners all around the world. Today is Friday, June 5th, 2026. I'm Dr. Linda Brubaker, Deputy Editor at JAMA. Today I'm joined by JAMA Deputy Editor Dr. Preeti Malani. Let's take a look at some of the newest research published in JAMA. First up, there are concerns that large population-based trials for new early cancer detection methods may impact care for other patients, even inadvertently. Dr. Mann and colleagues analyzed the effect of regional participation in the NHS Gallery trial, which used a cell-free DNA-based multi-cancer early detection test. Nearly 1.9 million patient referrals for suspected head, neck, lung, and upper GI cancers were recorded across 21 regions of England. During the first 6 months of the screening trial, regions participating in the study saw a modest increase in diagnostic delay rates for these suspected cancers. In contrast, there was a decrease in delay for non-participating regions, 29.6% compared with 26.3%. This initial 3.4% difference increased slightly during the next 6 months to 4.8%. Differences between regions faded after the first year. The investigators concluded that while the increase in diagnostic delay was modest and likely didn't change trial conclusions, future large-scale screening studies should plan for these subtle but real system-wide spillovers on healthcare resources.
Thanks, Linda. This is a good reminder to watch for operational ripple effects in big pragmatic trials. In this case, the observed difference might seem small, but across a large population, the effects are real for patients and systems. In an accompanying editorial, Drs. Sullivan and Booth provide perspective on these evolving blood-based cancer screening tools. They caution that the technology remains unproven for population-level screening, with potential system-wide risks that include unnecessary follow-up, false reassurance, and overwhelming a health system already stretched on diagnostic capacity. They urge future trials to prioritize careful science over a narrative that often oversells new technology.
In another accompanying editorial, JAMA statistical editors Dr. Issa Dahabre and Roger Lewis expand on the concept of spillover from clinical trials. They explain that in resource-constrained settings, increased demand from the trial, for example, added diagnostic pathways, can affect care for those outside or even within the control group, potentially introducing bias or limiting generalizability. They add that investigators should plan for, measure, and transparently report these potential effects, especially in pragmatic trials aiming to inform policy.
Well, let's move on to the next original investigation, which is about gastric cancer prevention. Now, gastric cancer prevention has long focused on Helicobacter pylori or H. pylori eradication, but questions remain about cost and benefit, especially at a population level. Drs. Lee and colleagues published a cost-effectiveness analysis using a Markov decision analytic model informed by a pragmatic randomized clinical trial in Taiwan. The investigators simulated long-term outcomes in a cohort who were offered either standard biennial fecal immunochemical testing or FIT testing for colorectal cancer screening or FIT plus a single H. pylori stool antigen test. The primary outcome was the incremental cost-effectiveness ratio of offering H. pylori stool antigen testing plus FIT versus FIT alone, measured as the additional cost required to gain one quality-adjusted life year per person. The authors found that inviting individuals to undergo combined H. pylori stool antigen testing and FIT was more cost-effective than inviting FIT testing alone. Specifically, co-testing was cost-saving in about 2/3 of simulations and cost-effective in the remaining 1/3 compared with FIT testing alone.
In an accompanying editor's note, JAMA Associate Editor Dr. John Inadomi explains that this analysis shows that a cancer screening intervention can save money. He He also makes the important point that no single approach will fit every country, and policymakers need to tailor screening approaches to their local context. Preeti, let's move on to a new study on cancer treatment.
There's ongoing debate about the role of adjuvant immunotherapy after surgical resection of non-small cell cancer. Dr. Shaft and investigators conducted a phase 3 randomized trial across 378 U.S. centers, comparing adjuvant Nivolumab, a PD-1 inhibitor, to standard observation after resection and completion of adjuvant chemotherapy and/or radiotherapy. To be enrolled, patients had to have a resected tumor of 4 centimeters or larger and/or positive lymph nodes without sensitizing sequence variants in EGFR or ALK. Over 900 patients were followed for more than 6 years, assessing primary endpoints of disease-free survival in the intention to treat, or as randomized, population, and also in the subset of participants with tumor PD-L1 expression of at least 50%. The authors found no significant differences in the full cohort of patients receiving nivolumab versus observation or in the subgroup with tumor PD-L1 expression. The authors conclude that adjuvant nivolumab after standard surgical resection and planned adjuvant chemotherapy and/or radiotherapy did not improve disease-free survival for patients with non-small cell lung cancer without sensitizing EGFR or ALK alterations.
Thank you, Preeti. That's helpful evidence to inform that concern. The European Renal Association meeting in Glasgow started earlier this week and runs through June 6th. Presentations include several impactful JAMA publications. One of these studies examines low-dose Rivaroxaban and cardiovascular events in advanced kidney disease. Dr. Bodve and colleagues enrolled nearly 1,500 patients with stage 4 or 5 chronic kidney disease, CKD, as well as patients with dialysis-dependent kidney failure in the TRACK randomized trial. These individuals also had additional cardiovascular risk factors. Participants were randomly assigned to either Rivaroxaban 2.5 milligrams twice daily or placebo for a median of nearly 2 years. The authors report that the low-dose Rivaroxaban did not reduce cardiovascular events. Primary outcome, which was a composite of cardiovascular death, non-fatal myocardial infarction, stroke, or a peripheral artery disease event, was similar between groups, 22.6 in the Rivaroxaban group, 20.7 in the placebo group. However, major bleeding was far more frequent in the Rivaroxaban group, 8.8% versus 6.0%. The author's take-home message: in patients with advanced kidney disease, low-dose anticoagulation for general cardiovascular protection may bring more harm than benefit.
In an accompanying editorial, Dr. Bunsell and JAMA Associate Editor Dr. Wolfgang Winkelmeyer note that the TRACK trial is the first dedicated placebo-controlled randomized trial testing anticoagulation for the prevention of hard cardiovascular outcomes, specifically among patients with advanced CKD. While the TRACK trial does not close the door on anticoagulation for cardiovascular protection in this population, the editorial authors note that the results set the direction for the questions that must be asked next, particularly regarding which patients are more likely to benefit and whether alternative oral anticoagulation strategies may prove effective or safer in selected populations with advanced CKD. Another new research study from the European Renal Association looks at measured and estimated GFR and health outcomes in chronic kidney disease. CKD diagnosis and staging hinge on estimated glomerular filtration rate, or eGFR, but it is unclear how well estimated GFR matches measured GFR and clinical outcomes. Dr. Fu and colleagues analyzed more than 6,000 adults in Stockholm, Sweden, with measured GFR based on plasma clearance of intravenously administered iohexol linked to their estimated GFR by plasma creatinine, cystatin C, or both, followed over 6 years. The primary outcomes were all-cause mortality and kidney failure with replacement therapy. Compared with patients with measured GFR of 90 milliliters per minute, those with measured GFR of 60 had higher all-cause mortality and kidney failure risks. These risks climbed steeply at even lower GFR levels, affirming the clinical threshold at 60 milliliters per minute for defining chronic kidney disease. Importantly, estimated GFR using both creatinine and cystatin C closely mirrored measured GFR for predicting mortality, whereas estimated GFR based on creatinine alone underestimated risk and cystatin C overestimated it.
In an accompanying editorial, Dr. Pylori and colleagues highlight the ongoing challenges. eGFR is easy, but imprecise, and measured GFR is gold standard, but burdensome. Combined creatinine cystatin C equations get us closer to clinical reality, but access, cost, and convenience remain obstacles. The authors encourage clinicians to be aware of the limitations of each approach.
Another study looks at Finerenone, a nonsteroidal mineralocorticoid receptor antagonist. For patients with CKD from glomerular diseases like IgA nephropathy, focal segmental glomerulosclerosis, and others, effective and broadly applicable therapies to preserve kidney function are limited. Dr. Nguyen and co-authors present a pre-specified exploratory subgroup analysis of the FIND-CKD trial, focusing on 903 patients with glomerular diseases among the more than 1,500 participants in the full study. Finerenone was associated with a slower decline in the estimated GFR compared with placebo, and reductions in albuminuria by over 40% at 12 months. The composite outcome of kidney failure, or a 40% decline of estimated GFR, was lower in the group receiving Finerenone. These benefits were observed consistently across glomerular disease subtypes, and serious side effects, including hyperkalemia, were not increased. This exploratory analysis suggests Finerenone may have an important role in preserving kidney function among patients with glomerular diseases.
In a viewpoint related to kidney care, Dr. Rentis and colleagues comment on the recently launched Increasing Organ Transplant Access, or IOTA model. This model links financial incentives to transplant center performance in an attempt to increase access and prevent the thousands of waitlist deaths that occur each year. Over the next 6 years, half of the U.S. transplant centers are randomized to participate in IOTA, while the remainder will serve as controls. The authors warn that an incentive-based benchmarking could unintentionally exacerbate existing inequities unless deliberate, ongoing monitoring and risk adjustment are instituted. The authors recommend that performance metrics should be linked with patient expansion to underserved groups, stratify quality outcomes by social risk, and ensure true transparency in waitlist communication. Preeti, there is a lot happening in kidney care. Let's look at some of the other new viewpoint and perspective articles. The first is interesting and on a timely topic, AI.
Yes, AI is inescapable these days, Linda, and it is increasingly present in the lives of clinicians. Drs. Singh and Mello discuss the rapid increase of AI decision support tools, often funded through targeted advertising. In this viewpoint, they warn that advertising, even when separated from clinical content, can influence prescribing behavior and clinical decisions. The authors call for clear guardrails, labeling, and transparency, and urge health systems and clinicians to scrutinize which AI tools are recommended to safeguard patient care that is free from bias. In a new women's health viewpoint, Dr. Ott highlights recent U.S. Food and Drug Administration shifts allowing osteoporosis medications to be approved based on bone density changes, not clinical fracture reduction. She cautions that surrogate endpoints, while efficient, may miss safety signals and true patient impact. Dr. Ott argues for better patient education, more thorough risk-benefit conversations, and greater attention to fracture prevention in perimenopausal women.
In a new editorial, JAMA Plus Trials, Editor-in-Chief Dr. Allison Huang and Editor-in-Chief of JAMA Health Forum, Dr. Sandro Galea, reflect on the unique challenge of running trials designed to inform policy. They note that health policy cycles are brief, equipoise is fleeting, and outcomes meaningful to policymakers often differ from traditional clinical trial endpoints. Let's close with some content for clinicians and patients. For clinicians, the latest JAMA Insights article focuses on lung ultrasound for CAP, community-acquired pneumonia, by Drs. Kumar and colleagues. The authors review lung point-of-care ultrasound, or POCUS, as effective chest imaging for pneumonia diagnosis when performed by trained clinicians. They emphasize that POCUS is portable, radiation-free, and provides immediate results. They also note that clinical integration and high-quality training are key while interpretation remains highly operator-dependent. Let's listen to JAMA Deputy Editor Dr. Kristen Walter discuss use of point-of-care ultrasound for diagnosis of community-acquired pneumonia with Dr. Kumar.
And what are some advantages, other than being able to interpret them at the bedside, of using POCUS versus the other imaging modalities?
There are, I think, three key benefits of using point-of-care ultrasound over traditional imaging modalities, particularly for pneumonia. The first of which relates to the availability of these devices, particularly in settings where there's not a lot of availability of CT or X-ray for the diagnosis of pneumonia, in particular, low income or limited resource settings. In those instances, you can use these tools that can connect to a smartphone or tablet to provide real-time diagnostic information, and that can be very powerful to improving the accuracy of diagnosis in patients who otherwise would not have that option.
Listeners should also check out the related JAMA video, which demonstrates the scanning technique and interpretation profiles of the Bedside Lung Ultrasound in Emergency, or BLUE, protocol.
The latest JAMA patient page explains peripheral neuropathy, the symptoms, common causes, and treatment options.
As we wrap up, don't miss this week's Healthy Dialogue podcast episode where JAMA Senior Editor Dr. Derek Angus talks with Dr. Sneha Kannan to discuss private equity's complex role in healthcare and what that means for clinicians and patients. And on this week's JAMA Plus AI Conversations podcast, Dr. Yulin Chuen speaks with Dr. Nigam Shah about AI and reading patient histories. Here's a clip from their conversation.
I mean, you've heard me say this before. I think healthcare is the only industry where we don't learn from what we did for our prior customers.
I have not heard that, but that is very telling. That is very telling. And I don't think our listeners really actually all know that either, but it's shocking.
We talk about it, right? I mean, we talk about it. We have words like the learning health system. We've had efforts all the way going back to 1970 from Dr. Alvin Feinstein trying to summarize a resemblance set of patients, as they called it back then. I mean, the intuition is still the same. I have everything that I have documented about this individual. One, I need to be able to summarize it and think about it in my reasoning. But second, what happened to other similar people? Because that is very informative when you have an evidence gap in treating the particular individual.
Also, there's a lot happening in medical news. You can tune in to the JAMA Medical News podcast that publishes every Friday and gives insight and context into the latest medical news. Subscribe and listen at jamamedicalnews.com or click on the link in this episode's show notes.
Well, that's a wrap for this week's JAMA Editor Summary. Thank you, Preeti, and thanks to our listeners for tuning in to hear what's new this week at JAMA. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Shelley Steffens, Dr. Krista Roberts, and Dr. Michael Lipnick at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening. This script was generated with assistance from AI tools, GPT 4.1 OpenAI, following an editor-developed prompt. The content has then been reviewed, edited, and approved by editorial staff.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.